All right, I think we might as well get started. Sorry for my voice, but I'm Christian Bergman. I'm the medical director of the VCU Department of Internal Medicine Grand Rounds. And today, just going to go through a few housekeeping items and then introduce our speaker and present. The code for the CME is on your screen currently, and we will also put that in the chat box, and it will be available at the end as well. Another quick thing, we are still in a virtual environment, so all questions, please utilize the Q&A function in the chat box. We will make sure we spend about 10-15 minutes at the end for facilitating your discussions. You can also raise your hand and ask to be unmuted. Lastly, I just want to say Happy Veterans Day today. And I have two facts for Veterans Day I just want to share. There are about 24 million US veterans as of 2020, and there are about 1.8 million women who are veterans in the United States. So please say Happy Veterans Day to your colleagues and wish you all well. Today, we are joined by a presentation by Dr. Sanyal. The title of today's presentation is NASH, the Other Pandemic. As you all know, Dr. Sanyal is one of our own. He is the professor of medicine, physiology, and molecular pathology in the division of gastroenterology here at VCU. He's also the interim chair of the division of GI, hepatology, and nutrition, and he serves as chairman of the NIH NASH Clinical Research Network, the NIMBLE Consortium, and the Liver Forum for NASH and Fibrosis. His research interests include all aspects of non-alcoholic fatty liver disease and NASH, as well as complications of end-stage liver disease. He has served as a member of numerous advisory boards to pharmaceutical companies and also the Liver Center at Yale University. He chaired the hepatobiliary pathophysiology study sections at the NIH and was a founding member of the Hepatology Committee of the American Board of Internal Medicine. He has also served as secretary as well as president of the American Association for Study of Liver Diseases, and he has authored more than 350 articles in publications such as Cell Metabolism, Nature Medicine, New England Journal of Medicine, Lancet, Gastroenterology, Hepatology, and the Journal of Infectious Diseases. He has an H index of 102. He has been continuously funded by the NIH for over 25 years, since 1995, and is the principal investigator on 4 large active NIH grants. He is the recipient of the Distinguished Mentorship Award from the American Gastroenterology Association, as well as the Distinguished Scientific Achievement Award from the American Liver Foundation in 2017, and the Distinguished Achievement Award from the AASLD in 2018. Dr. Sanyal, we are pleased to host you today and look forward to a good conversation. Thank you so much for joining us.
Thank you so much for that very kind introduction. Let me get my slide this up over here. And okay, hopefully you can see my slides. Right, good. Good. So it's a great pleasure for me to talk to you about a topic that's very near and dear to my heart, and that is non-alcoholic fatty liver disease, or NAFLD. And what I hope to do is sort of make the case that while we've all been obsessed with COVID for all the right reasons, there are other chronic medical diseases that are happening in the background that we need to pay attention to as well, such as non-alcoholic fatty liver disease. Here are my disclosures, and these will be available to anyone who wants to look at them. So a good place to start this conversation is to define what it is we're talking about. So non-alcoholic fatty liver disease is part of a spectrum of liver disease, which is characterized histologically by the accumulation of excess fat in the liver. Now, under the microscope, this fat gets washed out when you do a standard H&E stain, giving the liver a sort of a Swiss cheese appearance, as you can see on the slide over here. Now, there are 2 basic phenotypes. You can either get fat alone and that is called a fatty liver. And if it is not due to the consumption of alcohol, it's called a non-alcoholic fatty liver. There is also another lesion called steatohepatitis. So steatohepatitis includes not only steatosis, but also a very specific lesion called hepatocellular ballooning, where individual hepatocytes swell up and accumulate intracellular eosinophilic inclusions, and these are Mallory-Denk bodies, and scattered inflammation. So this is called steatohepatitis. Now, together, both non-alcoholic fatty liver and non-alcoholic steatohepatitis, or NASH, come under the umbrella term of non-alcoholic fatty liver disease. So why are we having a conversation about non-alcoholic fatty liver disease? The reason is because it has a very high public health burden. So let's review the data. Now, the impact of any disease is really a function of the prevalence of the disease and the impact on the individual patient who is affected. So looking at first the prevalence, somewhere between 20 and 30% of the adult population and about 10% of children in most parts of the world have excess fat in their liver, as identified by imaging. And if you look on the right on the table, depending on how you look for fatty liver disease, the numbers can vary anywhere from as low as 3 to 15%. And we're now talking about steatohepatitis, which is the more aggressive form of the disease, to up to 40 to 50% in tertiary care centers in liver clinics where patients are being referred for fatty liver disease. So it is expected that about 64 million people have fatty liver disease in the US, and somewhere between 5 and 10 million people actually have steatohepatitis. So there have been modeling efforts to try to understand what is happening with this disease in terms of the burden of disease. So if you look at the top, these show data for 2015. And what we have here is the total number of patients with fatty liver and NASH. And in this particular analysis, it ended up being about 83. When you include the kids and everybody else, it comes out to about 83 million people. Majority of these people actually have very little scar tissue. And only about 650,000 or so had cirrhosis. And if you break down these 633,800 patients with cirrhosis, most of them are compensated, and a minority of these patients, as you see, have decompensated cirrhosis, and very few patients actually are living post-transplant. Now, the projections based on what is happening with this disease around the country is that by 2030, this 83 million will become 100 million, and the number of people living with cirrhosis is going to increase to about 1.7 million. And when you look at this breakdown over here, you'll see there'll be a 2 to 3-fold increase in the number of people living with end-stage liver disease. Now, this has also been independently verified through the American Hospitals Association. So this is a national, what's called an SG2 outpatient forecast. So this analysis was actually pulled by the VCU health system, had nothing to do with me. And they also basically looking at national projections see that over the course of the next 10 years, if you are going to practice internal medicine, you're going to be seeing more advanced liver disease. And if you look at what is driving this advanced liver disease, it's fatty liver disease. It's about, there's a 10-year volume change by disease. It is one of the highest that we expect. So if you're going to practice internal medicine and be in a medicine program and practice either outpatient or inpatient medicine, this is a good time to start learning about this disease. Globally, here are the data. So this comes from the Global Burden of Disease Collaboration, which is funded by the Gates Foundation. And you can see over here that shown in purple over here, in proportion of people who are developing cirrhosis and dying from it from NASH continues to grow. Alcohol, of course, continues to remain a major other cause of liver-related death. So now we've talked about the overall burden of disease. Let's talk about what happens to the individual patient. And so I'm going to try to summarize what I feel is essential for internists to really know about this disease. Now, given the prevalence of the disease, I can guarantee that all of you have patients in your clinics with fatty liver disease, whether you've recognized it or not. So our goal today, if I can show you how to identify the people who you need to worry about and what to do about them, then my job is done. So let's move forward with that in mind. So the first point to make is that fatty liver disease is not an isolated liver disease. It's really part of a multi-system disorder. So we recognize that many of our patients with fatty liver disease also have vascular disease. They have diastolic dysfunction. Some even have heart failure with preserved ejection fraction, type 2 diabetes, and chronic kidney disease. And there's already data for each of these existing comorbidities that the prevalence of fatty liver disease is enriched in all of these populations. So we recognize these as risk factors for fatty liver disease. But the way I think about it is that these are all competing threats to life. Now, why are these things all happening in the same patient? Because there is an underlying state of metabolic stress that drives systemic inflammation and fibrosis. And at the root cause of all of this frequently is diet-induced excess adiposity. If you look at the prevalence of obesity, type 2 diabetes, hypertension, hypertriglyceridemia, and metabolic syndrome in general, in the US general population, and then related to fatty liver, you'll see there's an immediate step up. And then when you go to NASH, there is an even bigger step up, so that up to 80% of patients with NASH in the US are indeed obese. About almost half have type 2 diabetes, 70% have hypertension, and about 70%, about 2/3 or more, have full-blown metabolic syndrome. Now, what is scary is that the liver is a very forgiving organ. So it won't tell the patient something is wrong. And in the majority of patients who are identified, they're actually asymptomatic, or they have non-specific symptoms such as fatigue. So in the setting of appropriate risk factors, if you don't look for it, you're not going to find it. This is very similar to hypertension, that there are very few patients who will get a headache and you then say, maybe your blood pressure's up. You have to test, look for it, and treat it. And so this is an important message. So when we do evaluate, there are two things that we are trying to understand. First is the concept of disease activity, and the other is the concept of disease stage. Now, disease activity, imagine you're driving a car from here to Washington, and disease activity is the number of RPMs on your dashboard. It tells you how hard the machine, your engine, is working to move your car from here to Washington. Disease stage, so disease activity is basically similar to the RPMs on your dashboard. It's telling how much injury there is going on that is driving a normal liver to cirrhosis. Disease stage tells us how far you've progressed towards cirrhosis. So it's the odometer telling you how many miles you've actually traveled. So how close are you to your destination? So under the microscope, we recognize disease activity by the presence of steatohepatitis, which is more active than fatty liver, and by various activity scores for the individual components of steatosis, ballooning, and inflammation, whereas disease stage is related to fibrosis. Now, disease stage tells us how close you are to cirrhosis, and it is cirrhosis that leads to liver-related outcomes. And so it is no surprise that fibrosis is very important to understand how far the person has progressed towards end-stage liver disease. And it tells you how aggressively you need to tackle the problem. Now, these histologic markers have also led to a lot of work to try to better understand what they represent. And these are being leveraged for biomarker and non-invasive test discovery to evaluate disease activity and stage, which is currently done by histology and liver biopsies. So steatosis represents the metabolic perturbation that leads to fat accumulation. Ballooning represents hepatocellular injury from the metabolic perturbation. And of course, inflammation is the response to cellular injury. Now, one of the important things that we have learned over the years is that when you take patients and follow them over time, the disease phenotype can flip back and forth. So here are patients who had either fatty liver, borderline steatohepatitis, or definite steatohepatitis at baseline. And what you see in these hatched bars is what they had after they had a follow-up biopsy after a median duration of about 4 years. And if you look at the left over here, of those who had fatty liver, you can see that a fairly substantial proportion had either definite steatohepatitis, shown in red, or they had borderline steatohepatitis, so they progressed. Conversely, if you took people with definite steatohepatitis, you will see that a proportion of them have completely spontaneously cleared their disease, or they only had fatty liver, at the time of the second biopsy. And this is linked to fluctuations in weight, lifestyle, and et cetera, and other things that alter disease activity. So if you look at changes in disease activity and you plot the changes in fibrosis over time, a very nice relationship can be seen where when your disease activity goes down, your fibrosis goes down. And when your disease activity goes up, your fibrosis goes up. So activity drives the fibrosis, and this provides the proof of concept that therapeutics in the short term, if you can knock down the activity, this should translate in the long term into reduced fibrosis and thus improve the prognosis of the patient. So how does fibrosis link to the progression? So these are data that just came out literally 2 or 3 weeks ago in the New England Journal. So here we followed almost 1,800 patients longitudinally for about 10 years, median duration about 4 years. And you can see the clinical outcomes. This is all-cause mortality as a function of fibrosis stage. And you can see that this is the background mortality in stage 0 to 2. And then at stage 3, there is a step up, which is significant. And then at cirrhosis, you have a significant step up. So it is really the progression to cirrhosis, which is a sort of a milestone in the natural course of the disease, where things really have taken a turn for the worse, and you're now essentially tracking your way towards decompensation and death. Bridging fibrosis is a critical tipping point where you have enough disease that you're at increased risk, but where the disease is still relatively pliable. Now, you see that this increase in mortality is closely linked to a similar increase in decompensation of the liver. And this actually really drives the mortality in this population. Now, prior to stage 3, whatever mortality you see is principally from cardiovascular disease and from cancers. So there is an excess of cardiovascular mortality. There is an excess of cancer-related mortality. But once you get to stage 3, the causes of death change and you flip towards liver-related mortality, becoming the leading cause of mortality. And of course, no surprise, if you have advanced fibrosis, you have an increased risk of hepatocellular carcinoma. Now, I told you that the disease activity flips back and forth, but this flipping back and forth can also lead to improvement in fibrosis spontaneously. And we did not previously believe that, but here is data showing that even cirrhosis can regress spontaneously. So this is a study that currently is in press. What we did here was we took about almost over 1,000 patients who had cirrhosis around the country. Actually, this is a global study. And they had a biopsy at baseline at the end of 1 year. And we find that roughly about 176 patients on the second biopsy no longer had cirrhosis. Now, there's a lot of debate about whether this was sampling variability and there was some sort of a reading error. But when you look at the clinical outcomes in the people who did not show regression versus the people who showed regression, you see an almost 85% decrease in the incidence of liver-related events. And this is shown with a different fibrosis staging system, but further amplifies this magnitude of difference. So this shows that fibrosis progression is important. Fibrosis regression can also occur, and fibrosis regression does indeed result in improved outcomes. Again, providing proof that the progressive fibrosis, development of portal hypertension, and the decompensation really are the hallmarks and the milestones that drive mortality in this population. So based on this, we come back to our national model where we go from around 80-something million people with fat in the liver to about a smaller number with NASH, to about 5 to 10 million people who have NASH but have started scarring down their liver. And this is the population that we target for therapeutics. Once you get to cirrhosis, then your risk of clinical outcomes, which is hepatic decompensation, is about 3 to 4% per year. And at that point, once you decompensate, you're fast tracking to mortality with a 50% 1-year mortality. And that's when you start talking about liver transplant. Okay. So the other thing that has happened over the last year and a half is that fatty liver disease has also emerged as a major risk factor for COVID-related outcomes. So here's data with 62 million case records, of which about 1 million had chronic liver disease, 16,000 had COVID, 820 patients had COVID plus chronic liver disease. And this analysis shows that the mortality rate is 10.3% in those with chronic liver disease versus those 5.3% in those without chronic liver disease. And the hospitalization rate was 41% versus 23%. This has been replicated by multiple studies now. So having excess fat in the liver is an important additional risk factor beyond diabetes and metabolic syndrome and chronic kidney disease for bad outcomes in COVID. So let's summarize. NASH is common. It is enriched within populations with features of metabolic syndrome. Fibrosis stage is a key determinant of hepatic outcomes and overall mortality. Disease activity can wax and wane over time and modulates fibrosis progression or regression. So activity is tightly linked at the hip to fibrosis progression. Even cirrhosis can regress spontaneously, and this is associated with reduced outcomes. And NAFL is a risk factor for mortality and hospitalization in those with COVID-19. The other major story with NASH that clinicians and internists need to be aware of is the liver-heart connection. And what I'll try to prove to you is liver is actually the boss of the heart, even though we live under the heart. So the first data that started emerging about 10 years ago came from NHANES, which is this big national cohort study, where they found that patients with NASH actually not only had increased all-cause mortality, but they had increased cardiovascular outcomes. And so NASH was an independent risk factor with somewhere around a 3-fold increase in cardiovascular outcomes in this population that could not be accounted for simply by their background obesity, diabetes, dyslipidemia, etc. So this has led to a lot of work. And I want to recognize the work done by Shadab Siddiqui. You know, he was a fellow around that time when this data was first emerging. And over the last 10 years, he has published probably more than anybody else on the planet on this subject. And really much of what I'm going to show you here comes from his work. So normally, what happens is that you make triglycerides in the liver. The triglyceride is packed in very low density lipoproteins. This very low density lipoprotein then comes out. The triglycerides are cleared out in the periphery from lipoprotein lipase, leading to formation of intermediate and then low density lipoproteins. And LDL, as you all know, is an important atherogenic risk factor. Now, what happens in NASH is that you make a lot of triglyceride. When you make a lot of triglyceride, you make very large VLDL. It carries so much triglyceride that the normal lipoprotein lipase can no longer clear it. So you form LDL that actually has more triglyceride than it should. And this renders the LDL susceptible to hepatic lipases as it goes through the circulation. and they cleave the LDL particles into multiple small LDL particles. And these smaller LDL particles have a larger total surface area, more easily oxidized, more inflammatory, can more easily penetrate the arterial wall and lead to atherogenesis. At the same time, we did studies now many years ago using labels to see where they ended up. And we were able to show that as you go from normal to fatty liver to NASH, you get a big increase in cholesterol synthesis as well as triglyceride synthesis. But very interestingly, once you progress to cirrhosis, these decrease. And actually, this has been also linked to the fact that fat in the liver actually decreases once you get to cirrhosis. And this is, this increase in cholesterol synthesis has been linked to dysregulation of cholesterol sensing and increase in HMG-CoA reductase, even in the face of increased cholesterol accumulation in the liver, which would normally shut down HMG-CoA reductase. And at the same time, what is interesting is that the LDL receptors are actually decreased in NASH. So whatever cholesterol does come out, also the ability to clear it is somewhat decreased. And it would be fantastic to be able to do a study with PCSK9 inhibitors to see whether you can actually reduce the atherogenic risk in people who have less LDL receptors. But I think that's work still to be done. Now, progression to cirrhosis improves dyslipidemia, and you can see that the LDL particle concentration increases, but it does not decrease the amount of cardiovascular disease. So if you look at people with cirrhosis coming in for liver transplant evaluation and look at the etiology of the cirrhosis, we find that people with NASH have the highest prevalence, as shown in the red over here, of having 3-vessel and 2-vessel disease. So they also have impaired cardiovascular reserve. Atrial fibrillation is also overrepresented in NAFLD, and intermittent atrial fibrillation has now been linked as an important cardiovascular outcomes risk factor. And so this is something we track in our NASH patients also very closely. Furthermore, we did a study, or rather Shadab did a study, where he took patients who had NASH stages 0, 1, 2, and 3 and put them on a treadmill. And these are people who did not have any cardiovascular known history. And we find that as you go, the more scarred up the liver, the exercise time is decreased. Their peak VO2 decreases, but although these are fairly similar over here. But what is very interesting is that as your liver gets stiffer, when you exercise, your E to E prime goes up, suggesting that your diastolic filling is impaired. So you have progressive diastolic dysfunction. And it is now there multiple papers now showing that NASH with cirrhosis is associated with increased heart failure with preserved ejection fraction. So the more you scar up your liver, the more stiff your ventricles are. And there's growing data that very similar biology plays out in the myocardium as it plays out in the liver. We have recently further shown that as you go from stage 0 to stage 3 fibrosis, which is bridging fibrosis, you see over here that the prevalence of CKD increases as well. And when you look at the incidence of chronic kidney disease, if you look at the eGFR dropping below 60, for stages 0 to 2, it is about 2.17 per 100 patient years, jumps to about almost 3 at stage 3, and then a big jump in cirrhotics to 4.47. So once you get NASH cirrhosis, the decline in kidney function becomes a very important part of the overall clinical picture. And so a cirrhotic patient with NASH is not the cirrhotic patient with hepatitis C. They're completely different in terms of their overall medical status and medical profile. And many hepatologists actually really don't fully understand, appreciate these nuances. And I think we really need to move towards management of cirrhosis in an etiology-specific manner. So that is a perfect segue to now talk about disease evaluation and treatment. So let me make this simple. We really want to talk about 3 things. You want to ask yourself in a patient who has risk factors, obesity, diabetes, which is 2 out of 3 patients in your clinic, is fatty liver disease present? Does it require intervention? And if so, what intervention? So first thing we want to point out is fatty liver disease, again, is very, very common. If you look at your diabetes population, this is a study from Ken Cusi in Florida showing that if you're obese over here, look at this fatty liver disease prevalence, over 80%. So this brings us to this concept of pretest probability. If your pretest probability, if you have the level of obesity, that means you have 65, 70% likelihood of having excess fat in the liver. You probably don't need to do a whole lot of testing. You know, if you assume 3 out of 4 patients have excess fat in the liver, you'd probably be right. So the bigger question is, do you have the kind of fat that's going to kill you? Do you have the kind of fat in your liver that's going to lead to cirrhosis and kill you? And that really has led now to even the American Diabetes Association coming out with a recommendation that we need to be screening these patients. And we've started actually at VCU, a screening clinic. I wish we were getting more patients referred for screening for fatty liver disease, but this is work in progress. But at least we've got this moving now. So how do you screen and how do you do this? So, many years ago, when Dr. Richard Sterling was an upcoming faculty member instead of a senior faculty member, he worked on a project and developed a small score called the FIB-4 score, which was designed to identify people with advanced fibrosis in patients with HIV and hepatitis C co-infection. Now, this FIB-4 has now been translated across all liver diseases and is a central part of how liver disease is managed throughout the world. And this is Richard's and VCU's enduring contribution to the world of hepatology. So we published 10 years ago that the FIB-4 very nicely correlated with fibrosis staging within the liver. So since we know fibrosis is correlated with outcomes, we developed a classification system where we set a threshold of FIB-4 of 1.3 based on a high negative predictive value for having stage 2 or higher fibrosis, or FIB-4 over 2.6 based on a high positive predictive value of having either bridging fibrosis or cirrhosis, which is advanced fibrosis. And then we prospectively followed a fairly large cohort of patients through a national study called the NASH target study. And what you see over here, using these FIB-4 thresholds, is that the mortality rate, and these are data again reported per 100 person years, jumps from 0.07 to 0.42 to 3.08 as you go up. Liver events jump from 0.21 to 9. MACE jumps from 0.8 to 1.6 to 2.5, again making the case of this collinearity between the liver and the cardiovascular disease, and hepatocellular carcinoma also increases. So the overall OROC for FIB-4 for predicting mortality is 0.84, which is pretty darn good. And if you take a deeper dive, you can see most of this information is coming actually from stratum C, which is FIB-4 over 2.6. And then furthermore, over here, you're seeing FIB-4 with major adverse cardiovascular events also. Now, by the time you get to that point, your disease is really advanced. And the further along you are in your disease course, your treatment options are more limited. So based on that, we developed, this is back in 2015, we presented this, and now this is sort of incorporated in multiple practice guidelines throughout the world, is if you look at a FIB-4 less than 1.3, the negative predictive value for having a likelihood of a liver outcome is very, very high. So these are people you can follow with simple lifestyle interventions and recheck them at a couple of 2-year intervals or so. If you have a FIB-4 over 2.6, you already have advanced disease. You're sitting on a time bomb. So these are the people where we do a secondary test with a fibroscan or now with MR elastography and manage these. If that confirms that they are indeed have significant scarring, even without a biopsy, we manage them as though they have advanced fibrosis and close to cirrhosis and decompensation. People in the middle, you got to look at their overall risk profile and have a one-on-one conversation. And we frequently will do a secondary fibroscan. And if the fibroscan again confirms that they are sort of in the middle somewhere, or then in that case, we follow the patients. But if they do have high-risk features, then we may consider selected individuals for liver biopsy for further confirmation. So this is done on a case-by-case basis. And we really would encourage all of you to start using FIB4. If you have an obese, diabetic, hypertensive patient in your clinic, please check a FIB4. All you need to do is get a CBC with platelets and a hepatic panel. And if you put FIB4 in your cell phone, you will immediately get a calculator. You put the age, AST, ALT, and platelets, and you will get a FIB4 score. If it's less than 1.3, you don't need to worry too much about it. If it's more than 1.3, send them to us. We'll do a fibroscan, and we will assess if they have advanced disease. We'll take care of it. If not, we'll work with you to optimize their liver care. So this is what is currently happening throughout the country. If you look at the population at risk, people are either ignored. We frequently see patients who come in with their hepatocellular carcinoma or with decompensated cirrhosis. And we ask them and they say, yes, my liver enzymes have been elevated for 20 years, but my PCP told me, don't worry about it. Everybody's liver enzymes are up. And so it's been systematically ignored. And then occasionally it's identified and triaged for care. But because these patients are asymptomatic, the large bulk of these patients are in the realm of primary care or in the diabetes clinics. So we really need those of you who are practicing primary care or in type 2 diabetes to pay attention to the risk factor profile. You are already looking for diabetes, you're looking for CKD. Take that extra step, get a hepatic panel along with the CBC with platelets and get a FIB4 in this population. The pretest probability if you have diabetes, obese, and you're hypertensive, that you have fat in the liver is very high. You don't need additional testing. What you really want to know is have they started scarring down their liver? And if their FIB4 is over 1.3, send them to us. So this is the paradigm that we would like to move to, where we screen, identify the high-risk patients, and then let us help manage this in a multidisciplinary manner. So how do we manage? Once again, we come back to this concept of the disease being a part of a multi-system disorder. And each of these different end organs represents a competing threat to life. So our goal of management is for vascular diseases, blood pressure control, atherogenic risk optimization, reduce vascular inflammation. For the myocardium, improve your arrhythmogenesis, diastolic dysfunction. From a liver point of view, prevent cirrhosis, because if you don't prevent cirrhosis, the likelihood of dying from liver disease is extremely low. From a pancreas point, preserve your beta cells, stabilize your GFR. So you got to treat the root cause. So what we frequently do, and we see this in our patients with fatty liver disease, the average patient is on 10 to 15 drugs. But what we really need in the future is better treatment of the root cause. So if you look at the root cause, it's one of the things that weight loss has been shown to be beneficial for each and every one of these end organs. And there are, of course, established therapies for each of these end organ diseases. So much of this is background therapy that many of our patients are already on. So the one I'm going to focus on is really, again, weight loss, and then talk a little bit about GLP-1s, which I think are going to be very important in the management of NASH. So these are data with bariatrics, and it shows that with bariatrics, you not only have improvement in vascular disease, but if you look at histology, steatosis resolves, inflammation ballooning resolves, 40% of people with fibrosis improve, but 60% don't, and 12% actually get worsening. And the overall grade quality across the bariatric literature is generally low. Furthermore, now there's an emerging story that following bariatric surgery, there is an increase in suicide risk. And we can talk in Q&A about why that may be so. So there are a lot of work going on trying to improve weight loss. We are just starting a trial on mindfulness to use simple measures to improve weight loss, and basically focusing on mindful eating, awareness of physical sensations, thoughts and feelings related to eating, acceptance and judgment of these sensations, and awareness, and a step-by-step change of daily patterns and eating habits. There's already emerging data in the metabolic space on the role of mindfulness in management of metabolic syndrome. We want to extend this and generate the data for liver disease. But from a pharmacological point of view, the main story right now are the GLP-1s. GLP-1s have, such as semaglutide and liraglutide, etc., dulaglutide, have not only produced weight loss, but they have a number of systemic effects, from cardioprotective effects, natriuresis, blood pressure reduction, reducing liver fat, improving glycemia, etc. And so from NASH perspective, it reduces inflammation, triglyceride, and fat storage in the liver and improves glucose metabolism. So these are data from our New England Journal paper from a few months ago, where we showed with semaglutide that you have almost 59% resolution of NASH. But this did not translate easily into fibrosis improvement within this 18-month trial. But if you look at those whose fibrosis progressed, remained the same, or worsened, a story emerges. So if you look at the pink wedge, which is the proportion of people whose fibrosis worsened, here you see in the placebo arm, it's 18.8%. If you go all the way to the left and start with semaglutide 0.1 and work your way to 0.2 and 0.4, the proportion of people with worsening progressively decreased down from 10 down to 4.9%. So when you remember, GLP-1s do not have any receptors in the liver. So all of their effects are outside the liver. So for that to translate into reduced steatosis, which then leads to less inflammation, cell injury, and then eventually less scarring, the first thing that happens is that the fibrosis slows down, and that's what you're seeing. So this is currently in phase 3, and we're leading the global phase 3 trial, which we hope will really establish GLP-1s as a mainstay of treatment of NASH. Another class of molecules leverage what we had previously published with pioglitazone, and we didn't have time to show you today, but this is a pan-PPAR agonist. So it's PPAR alpha, beta, gamma, and delta. And what you see is that it's a progressive stepwise improvement in NASH resolution. These data also just came out 2 weeks ago in the New England Journal. And here we show that it also improved fibrosis reduction. And if you look at a combined endpoint of NASH resolution and fibrosis improvement, highly significant improvement for lanifibranor, 1,200 milligrams. So this is also moving into phase 3. And again, we are leading the global study for phase 3. Now, if you look at all the different classes of molecules, we've talked a little bit about thiazolidinediones. What you want from an ideal NASH drug is for it to make you lose weight, optimize your atherogenic risk profile, improve MACE, stabilize GFR, improve glycemia, and reduce NASH progression. So as you can see, thiazolidinediones, the data for NASH progression is mixed. It causes weight gain. So saroglitazar, which is a PPAR alpha gamma, is weight neutral, has a fantastic effect on atherogenic dyslipidemia, already approved in Asia. We have completed studies and published studies showing that it is very good for atherogenic dyslipidemia, and we're actually beginning to use it in our post-transplant population and moving forward with a separate indication for this, and improving glycemic control. We don't yet have data for MACE, and we need longer-term data on NASH progression. Bile acids are being looked at, but bile acids can cause pruritus, and bile acid-related therapies can also increase cholesterol. So I think there's several question marks here. FGF21 is another cytokine that's being looked at, very good for atherogenic dyslipidemia. We need more histology data. Thyroxine beta receptors are relatively liver-specific and have a very good effect on atherogenic dyslipidemia. It improves NASH, but whether it improves fibrosis remains an open question. We've already talked about GLP-1s, and there are other molecules such as fatty acid, bile acid conjugates that also reduce liver fat, have been shown in phase 2 to be good and are in phase 3. And again, we're leading this trial as well globally. So where I think we're going to land is that we will initially, in patients with risk factors, evaluate the patient, start them on a path towards optimizing their body weight and body composition, protecting their muscle mass while reducing their liver body fat. And then if they need statins, don't be afraid to use statins. Statins are extremely safe in this population. And you may combine it with fibrates, particularly if their triglycerides are increased, because statins don't really do much for that. I think GLP-1s and SGLT2s are going to become mainstay background therapies, particularly in the diabetic population. And one thing you should do is try to minimize the use of insulin. Insulin makes you gain weight and actually can also induce hepatic steatosis. So use it sparingly, as indicated. Once this is done, patients should be followed for some period of time and reassessed. And for those who have active disease and advanced disease, that's where I think liver-specific therapeutics will come in play, particularly in the cirrhotic population who are closest to clinical outcomes. Of course, and then ultimately the goal is to improve the overall health and of the patient with the eye to improving mortality, healthcare cost, their ability to function, and their managing their quality of life. So with that, I will stop and take questions. Thank you.
Wonderful presentation. Thank you so much, Dr. Sanyal. We have a number of questions here in the chat box, so I want to get through them. As a reminder, you can use the chat, ask to raise your hand, and we can unmute you or submit something through the Q&A. So I think first question here, can you provide more information about the NAFLD screening clinic? Maybe how to make a referral, any contact information?
Yeah, so I think if you send an email to either, or use through a Cerner message to HEP NASH provider, or to the West 14 hepatology pool, I can send you the exact language and the exact thing to send through Cerner. But Cerner is changing to Epic, so we're constantly changing. So let me touch base with the staff. So I'll give you an Epic solution to this because I think we have only a few more weeks of Cerner left. Yeah. So
maybe in January or something, we can send something out through the
yeah. And Dr. Askarpur is leading the attack both on Epic as well from our division, and he is also very much leading the charge in terms of getting the NASH screening clinic going. So it's on Friday mornings on North 8.
Thank you.
So particularly if you have type 2 diabetes and you have, high FIB4, we'll be very interested in seeing those patients.
So there were two questions, just to piggyback on your FIB4. There were two questions about whether that would be incorporated into Epic. Do you have any comments?
I would love to see this incorporated in Epic so that, at the VA hospital, the FIB4 is already part of the electronic medical record and gives you an alert. And so I would love to see this incorporated in Epic. We have still numerous gaps in what we feel are core services that our division provides with respect to Epic. So it's work in progress, but yes, it is definitely on my wish list that if you order a CBC and a hepatic panel, it will automatically give you a FIB4 score. And maybe, I don't know what the Epic mechanism for generating an alert for the physician that, hey, FIB4 is high, you may want to consider X or Y.
Dr. Sterling chimed in and said that it's supposed to be in Epic, but we will see. So
yeah, we shall see.
Would be great to get it in. The second one is maybe a comment, how do we make screening easier for co-locations, primary care and hepatology to have interdisciplinary clinics? Any thoughts or plans around that?
We have lots of thoughts and plans around that. And I don't want to put Dr. Syme on the spot, but we have been talking about the potential for a liver institute, a critical part of which would be a multidisciplinary, program. I would love to see a hepatologist within the diabetes clinic. We already started, we're a little stretched thin on the ground right now. But we would love to go to CMH. We would love to start the screening at Rappahannock. We've had conversations with family practice with Dr. Strayer's group about doing some screening. Our concern is we don't have the hands to, right now. So that becomes an issue of human resources, space, and other things. But it is very much centrally located on our radar.
Phenomenal. Thank you for sharing. Another comment here, does intermittent fasting or restricted eating have a positive effect in reversing NASH?
Well, we don't have a lot of data on NASH per se. what we do know is that intermittent fasting has some metabolic benefits. The key to a lot of these type of approaches, whether you go on a ketogenic diet, there's so many diets out there, right? Is the sustainability of your approach. It is the idea, the key word in lifestyle change is the word life. You've got to make changes here. And, some of the things that we've learned is that lifestyle changes work best when the whole family adopts the change. So there's a very interesting study that Dr. Siddiqui did where he looked at spouses of people being referred for liver transplant. And we found an incredibly high prevalence of NASH. And we actually found a number of spouses who were cirrhotic and actually had no idea they had liver disease. And, so it makes the point that when one person in the family is asked to go on a diet, and typically most people envision going on a diet means you're living on lettuce and, salads, and while the rest of the family is eating cheeseburgers and pizzas. So the perception is that you're being punished. So it really has to do with living healthy. And when the whole family makes a change, given in an internet era, the number of options we have for not only healthy cooking does not have to be boring and a punishment, and that's a message that we should give out.
Yeah, this is a good segue into our last question here. What type of dietary counseling do you typically provide for these patients?
So I use a common sense approach, which is, focusing on the family, looking at the family unit and trying to understand what they eat and why they eat the way they eat. So if you know one patient, one patient. So everybody's circumstances are different. So if you are a nurse working the graveyard shift and you're coming home early in the morning and you have to get the kids off to school and then your husband off to work and then take care of family things, get a little sleep, get up in the evening, run some errands, and then come back to work. It's a very different paradigm, asking them to do things that are, so you have to understand, you have to have a conversation with the patient about what's feasible and why they eat what they eat and how they eat. So I try to focus on portion control, avoiding seconds, avoiding some things that are clearly not good for you, like refined things that are very high in refined sugars, slowly increase things that have fiber in them. And also, I really try to emphasize this whole idea of early to bed and early to rise. On the average, Americans are sleeping an hour and a half less in 2021 than they did in 1980. And this is having an impact on all your clock genes, and the clock genes control your metabolic machinery. And so there's a lot of data on disrupted clock genes and metabolic syndrome. And so getting into a habit, nothing good goes down your throat after 10 p.m. because you're raiding the fridge, you're getting into the popcorn, all of that kind of stuff. So, developing. So I think a focus on healthier lifestyle, and where I think the future is going to be, is not about NASH or diabetes or heart disease. It's holistically talking about metabolic health or lack thereof. And we need to be more metabolically healthy so that we can all live, because, this whole syndrome is now evolving into Alzheimer's and heart failure and CKD and peripheral vascular disease and liver disease and pancreatic disease. Every organ's affected. So we really need to simplify this and develop this concept of metabolic health and health as a positive construct and not really the absence of disease.
One more question in here. Can you comment on soda or high fructose intake?
Yeah, really bad for you. Short answer, very, very bad. You get 5 demerits for drinking a soda with a high fructose. Fructose is, it is a paradox of the capitalist system that we give huge subsidies to farmers to grow corn beyond what our needs are as a society. And instead of distributing it to people who don't have food around the world, then that corn gets compressed into creating high fructose corn syrup, which then gets put in all kinds of food, which we sell to unsuspecting public. When they get sick, we have $1 billion pharmaceutical industry and academics who make a career out of doing clinical trials like me, who show up and say, hey, look, we have treatments for you. And so the whole thing, I think, is absurd, but that's a whole separate grand round where I can get up on my soapbox and talk about what ails this country.
One more comment here in our chat box. Great talk. I did not see the incidence in Australia of non-alcoholic fatty liver disease. And then it just says, am I mistaken? Maybe they're asking.
Aussies have got it bad just like us.
Okay, yeah. I have a last comment. You alluded to mental health a little bit, and I just wanted to piggyback on this a little bit. In terms of weight loss strategies, you also alluded to yoga or mindfulness and behavioral change. We all heard a lot about Noom, which is the company that is utilizing behavioral approach to long-term weight loss. Can you comment on the link between mental health and maybe dysmetabolic syndrome? It may not be directly related to
So this is almost another grand round, but I'm actually giving a talk at our national meeting on this subject in a couple of days. So there's a whole lot of issues from a mental health issue, from the genetic background to eating disorders, to things like PTSD and things that drive people to eat what they do. Then there are socioeconomic factors. Mental health is a multidimensional construct where you not only have, whether you have a defined disease or not, but whether you are functioning intellectually and cognitively to your maximum capacity. So there is a tremendous linkage between multiple mental, for lack of a better term, mental health disorders and metabolic syndrome and fatty liver disease. Some of the changes in the gut microbiome and the products made by the altered gut microbiome in obesity have now been also shown to feedback on the brain. Similarly, cytokines that are released from the liver and adipose tissue also impact the brain. So you have the systemic pro-inflammatory milieu also affects the brain and leads to neuronal degeneration. So on top of that, you have cognitive deficits. Alzheimer's is now being linked to obesity, diabetes, and dyslipidemia as well. And so to really understand it, you have to do a deep dive. We published a study some years ago, and what we found was that people with fatty liver disease, they are, in terms of their ability to change, in what we call a pre-motivational state, where in their mind, even though they're being told they're obese, they don't feel they have a weight problem. At VCU, we started a pediatric obesity program many years ago when Rod Laver was the chair. And he came and told me that something they discovered very interestingly is that when they went out and talked to the kids about losing weight and to encourage them, some of them said, well, if you lose weight, you're more likely to get a date. They said, no, actually, if you lose weight, those are the kids who can't find a date because nobody looks like them. So, it's a very complex issue. But depression plays a very important role. And I think the increase in suicide after bariatrics is linked to people who eat to cope. And if you take that coping mechanism away and they're barfing every time they eat, and you don't give them an alternate mechanism, then you promote that depression. Similarly, addiction spikes. There's a lot of data about alcoholism after bariatric surgery, particularly in women. And we now have seen a lot of patients come in with an albumin of 1.5, complete nutritional train wrecks, and who have significant alcohol-induced liver disease post-bariatric surgery. So it's a very, very complex issue. So, unfortunately, because of time, can't get into it in more detail. Love to talk one-on-one. If come by, send me an email, we'll talk.
Thank you very much. Dr. Syme, any comments?
I just wanted to thank Dr. Sanyal for an outstanding grand rounds, but also importantly, I want to thank both him and the liver team for the amazing work they do. They really do publish regularly in the top journals, and I think bring great care to our patients here at VCU and the Commonwealth, but far beyond. So, a very impactful group of colleagues, and Dr. Sanyal certainly leading it. And I think I also want to thank members of that team who helped lead the department's research efforts and their amazing response to COVID. So Dr. Sanyal got very involved in COVID trials when it's not his area, just to help out an academic medical center do the right thing. So, personally grateful to you, Dr. Sanyal, and all your colleagues in hepatology and GI for the services to our institution and our patients.
Oh, thank you so much. That means a lot. We have a fantastic team. I know I could not be more proud of our guys, and particularly, Dr. Sterling is a very senior person, but I still think of him as one of my kids. So
we'll talk more about that offline.
We'll talk about that offline. But FIB4, is the way it's used in every liver clinic around the world today, and that's his contribution. No one can take that away. That's VCU and his contribution. Shadab has contributed so much. Jazz is, that's a whole separate conversation, has published is sort of a global leader in understanding how the liver affects the brain. So I am very fortunate in having actually had to work with all of these guys and be, for them to be associated with all of them.
And finally, I just wanted to add my vote of thanks to the veterans, and we have several veterans in our department, so really appreciate all you have done and continue to do for our country. Thank you.
Thank you so much. We are all excited to be part of the family, so maybe we can be adopted cousins over here in geriatrics. So thank you so much.
All good.
Wonderful grand rounds. Thank you, Dr. Sanyal, for everything. And for everybody else, the code for the CME is in the chat box. We appreciate your time, and we'll leave the chat up here just for a minute to make sure everyone gets the contact information. But have a great day and happy Veterans Day. Thanks.
Thank you, guys, and happy Veterans Day.